Welcome to Elephant in the Room, a podcast featuring real conversations with real therapists on the elephant in every room, trauma. With this show, we are aiming to share insights from professional practitioners on trauma, its impacts, as well as various modalities and resources on healing for survivors. This podcast is produced by the Breaking Free Foundation, a Canadian registered charity that supports trauma survivors in reclaiming their lives and finding healing. All of the therapists interviewed on this podcast are members of the Breaking Free Foundation Trauma Practitioner Network. My name is Amber Craig. I am a trauma survivor, one of the co-founders of the Breaking Free Foundation, and the proud host of this podcast. Today we are joined by Dr. Magdalen Schluter, registered psychologist in Calgary, Alberta. Magdalen has substantial experience working with mental health concerns like depression, anxiety, life transitions, as well as specializations in addiction and PTSD. Please welcome to the podcast, Magdalen. Thank you for being here.
Hi, it's a pleasure.
So I always start with a brief intro because I like to give you the opportunity to explain more about your professional background and the areas of expertise that you have. So I'll hand it off to you.
Yeah, absolutely. So I'm actually a Calgary grad. So I did my grad school and my residency here in Calgary. So I've been around the block. I come originally out of an addiction background. So you'll see, as you mentioned, I do continue to work with clients who, are experiencing harm from kind of engagement in substances or potentially addictive behaviors. But I really focused my training on both kind of formal assessment and treatment of other complex concerns, including trauma as well. So when I was completing my doctoral residency, I spent half the time actually working at the Operational Stress Injury Clinic, which is a specialized program for RCMP and veterans and military professionals, really who have experienced a really fairly broad range of traumas. And so I worked with everything from, individuals who have witnessed, really horrific events while deployed overseas, to those who've experienced sexual assault in the context of their job. And it was a really great opportunity where I really did develop that specialization and training, in trauma. So I have those areas of specialization. But I have also been able to develop expertise across those range of concerns, depression, anxiety, life transitions, clinical perfectionism, things like that.
So that's something I kind of want to get into is just a bit more on, we obviously, our audience is primarily the trauma community. So speaking more to PTSD and other complex concerns, you kind of described a bit of your professional background there. What drew you specifically to be interested in working with that population?
Yeah, that is a really great question. And folks, one that people always ask me because it seems a little bit odd, I think, for some people. But I will say, I think the addiction focus, especially for my research, actually catalyzed some of that interest just because addiction, it is a little bit complex and it often presents alongside other challenges. And so, when I think about complex populations or complex concerns, I really am thinking about clients who are experiencing multiple concerns, right? Addiction or PTSD plus something else, depression and anxiety, right? Those mixes, or individuals who are experiencing challenges like PTSD, where that trauma-specific training is really needed, because otherwise there is a real risk of making things worse as opposed to better. So reasons being really drawn to that. Again, most clients don't have just one thing going on. Often there's multiple, and being able to think about that, having a really good case conceptualization and understanding how these different problems are working together and interacting, maintaining each other even. Really I like thinking in that way. It works really well with the model that I work from. And being able to say, okay, what can we target first that's the most likely to get the most progress towards your therapeutic goals kind of right from the output or outset.
That's a really good segue into my next question, because I think we definitely see with the population we work with that people will have multiple diagnoses, PTSD and something else, like as we know, that doesn't usually operate in a silo. So For people that might not realize that depression and PTSD, for example, might have very similar symptoms, can you just walk through some of the similarities and where there might be overlap between depression and PTSD?
Absolutely, yeah. I would say kind of the biggest area of overlap that we see is kind of those changes in moods and thoughts that can happen. So, for example, after a traumatic event, an individual might feel a low mood and have changes in their thoughts about kind of themselves, the future, and even the world as a whole. We actually call this the cognitive triad in depression, but you see changes in those same areas in trauma. So I'm broken because of what happened. No one cares about me. My life will never get better, or it's going to be like this forever. We see those thoughts in both populations. And then the second really big one is social withdrawal. It's a key feature of depression. We know it actually maintains depression in the long run, right? Withdrawing from friends and family. But individuals with PTSD also withdraw, right? But often for different reasons. You also might see things like irritability and anger, problems with concentration, and even sleep changes in both as well.
And just on the flip side of that, what would be some like key differences between depression and PTSD that clients should be aware of?
Hmm. Well, what's really interesting about PTSD is that a lot of the symptoms seen in depression can be seen in PTSD, or at least on the surface, kind of look very similar. But even in those areas of symptom overlap, often the cause of the symptom is different. And if we dig deeper, we can kind of distinguish between the two. So, for example, with depression, there do seem to be changes in neurotransmitters that regulate that sleep wake cycle. That's going to lead to changes in sleep, or kind of like what we call rumination of those depressive thoughts, continuing to kind of replay those negative thoughts over and over and over in your head when things are quiet, when you're lying in bed. That's going to really interfere with sleep. So you're going to see sleep changes. In PTSD, it's going to be things like nightmares and the nervous system changes, like, right? That fight, flight, freeze system that's so hyperactive that's going to create real problems with falling asleep. So, on the surface, this one symptom, sleep changes, might look the same. But if we dig a little bit deeper, we actually see it actually looks quite different under the surface. And so treatment is also going to look different. Other really key differences for PTSD that's really going to set it apart from depression, that hyperarousal, that overactive nervous system I mentioned, the intrusive symptoms that are what we often think of when we think of PTSD, right? Really intrusive, upsetting, distressing memories of the event occurring, in the day or at night in nightmares. And then the avoidance, that avoidance of both the memories, those internal reminders, as well as people, places, things in our world that are also going to trigger those memories of the trauma. That's a really key distinction that's more unique to PTSD. Whereas with depression, that pervasive sadness or feelings of emptiness is going to be much more pronounced and unrelated to trauma reminders. So it's going to be there regardless of whether someone is experiencing reminders of the trauma. And then that loss of interest or pleasure in activities that have been previously enjoyed. It can be present in PTSD, but it's so much more common um, in depression. And then this feeling of, like, often when you talk to someone with depression, they often report a feeling of like sluggishness or heaviness, like their body is weighed down. Even if they've slept, that doesn't go away. And that seems to be really unique to depression. Whereas with PTSD, you're getting that hyperarousal nervous system reactivity that's happening a lot more.
That's really helpful context, I think, for that's something we haven't ever covered on this podcast is just talking about those two distinct things. I know you mentioned that it can be quite common for people with PTSD to also meet the criteria for depression. Do we have any data on how common it is, or can you speak to what you see in your own practice?
Yeah, it's also a great question. So Depending on the population, there's always, some differences, but I think it's anywhere between like a third and a quarter of individuals with PTSD will also have a depression diagnosis at the same time. Um, in my practice, I will say a lot of individuals definitely often with PTSD, show some of those features of depression. I don't know that I would make like the depression diagnosis, even if on the surface they meet those depression criteria, whether or not it's actually depression or PTSD that looks a little bit like depression. That's sometimes kind of a big question. But yeah, anywhere kind of a third to a quarter do seem to also have that depression diagnosis.
And just, playing off of that point, when would you say it's helpful to diagnose depression separately in someone that has PTSD? And on the flip side, when is that not helpful?
Yeah. So I will caveat here, there's different clinicians have different opinions on this. I'm the type of person I like to make as few diagnoses as possible if someone's coming in for an assessment, or if I'm offering diagnoses, as few as possible that are going to explain the symptoms. I don't find it particularly useful sometimes to give a list of five different diagnoses if the symptoms of depression, for example, really are largely explained by the trauma. Um, and again, if we're digging deeper and seeing that, like on the surface, what looks like depression really may be best explained within that PTSD diagnosis and how those symptoms are functioning looks more like PTSD. I'm not going to make a diagnosis of depression separately. It's not useful and it's not going to inform treatment. So, leading in, when is it actually helpful? If the depression symptoms are not clearly linked to the trauma, seem to be coming from a different source, or they're severe enough that they're going to interfere with trauma treatment, um, then I find it appropriate to make that separate diagnosis, because you're looking at a slightly different treatment approach in that case of needing to address the depression as something separate from the PTSD.
So you kind of started to answer my next question, but what would you say are the risks, if there are risks, if depression is overlooked in somebody
Mhm.
with PTSD, if everything is being attributed to trauma alone? Are there any risks of not identifying those two things?
Yeah, absolutely. And I will even say, like, depression can arise out of trauma. Um, Not everyone needs to have PTSD, right? Coming from it. The depression can also come out of the trauma, but look different from PTSD. But there are circumstances if a person does have criteria for both, right? There's more going on than just the PTSD. It can actually interfere with trauma therapy if it's severe enough. Trauma therapy is not an easy process to go through. You know, it's really intensive and it takes a lot of energy. And if an individual's mood is so low, or there's thoughts of suicide, and they've really disengaged from activities and friends, essentially they're missing really critical coping skills and a social support network that can actually help them tolerate and go through that trauma therapy process. And so making that separate diagnosis in order to actually help them do the trauma therapy can be really, really important. Um, we've also seen that, if the depression is independent from the trauma therapy might not resolve everything. And if you have depression symptoms or depression that is unresolved and unacknowledged, it actually increases the risk of the reemergence of PTSD symptoms down the line, or a relapse back to PTSD in response to another stressor. So, addressing that depression either before or after trauma therapy, can actually is kind of in a really essential piece to providing that comprehensive treatment that's really going to help the individual heal and grow from the trauma and really reduce that risk that that PTSD piece and those really distressing symptoms are going to come back in the future.
So you kind of touched on this earlier in our conversation, but we in our community have a lot of conversations around labels and whether or not those labels can be helpful in a therapeutic process or not. But considering our conversation about, these kind of dual diagnoses between depression and PTSD, how do you approach conversations with your clients about diagnoses without making them feel like they're boxed in or that they have labels?
Yeah. So it kind of depends on the population as well. Like for some individuals, they might already know or be pretty sure they have PTSD and they just need kind of confirmation. With first responders, especially kind of military and RCMP police, there's a lot more awareness in that community now about PTSD. And some stigma is definitely reducing. And so, like working with that population, in all likelihood, if they're coming to me, very often it's because they believe they have PTSD and they want help. And so, they're actually looking for that label in order to help access specific treatment or provide kind of a framework for understanding what they're going through. And just normalizing that PTSD, it really is just a name for a set of experiences that, again, provides that framework for understanding why they're experiencing what they're experiencing, providing some clarity around that, and being able to say, and we know there are treatments that work for this that can help you. Um, in other cases, though a client might be coming to me for a completely different problem, and I do see this fairly often in my practice, initially coming in for, self-esteem, assertiveness, depression, but kind of in the context of our work together, eventually they trust me enough to share that history of trauma. And just in kind of exploring some of that, I might hear some of those key symptoms that make me think, maybe there is a trauma disorder, something like PTSD, that's maybe actually explaining the what we call the presenting problem, right? Why they've come to me. And this is definitely a trickier case because simply saying, "Oh, I think you have PTSD," that's definitely going to be more likely to be labeled, to not be taken right, to make the client feel boxed in or even unheard. Um, and so, I might not even offer that right away, but might just draw on like trauma treatment practices and kind of just as part of addressing the presenting problems, if I know that it's likely, coming from a trauma source. And then when we're kind of getting some momentum, have more trust, have much better rapport, gently exploring the source of the problems can help the client kind of link their current challenges to the traumatic event or events themselves, right? If they're able to make that link themselves, they're going to be much more likely to accept when I then say, you know, here's all the symptoms I've kind of heard, not just what you initially came in for. What do you think about that? What do you know about trauma disorders? Have you ever heard the term PTSD? Like get their kind of opinion on it as well, give them the chance to try and explain it, and make that connection themselves. And then I get to just kind of fill in the gaps so that the diagnosis, it isn't coming out of the blue. We're on the same page. They know I'm understanding and hearing everything that they've been telling me. Again, normalizing, right? It's just a name for a set of experiences, but maybe this is helping provide a framework of understanding, a set of experiences they might be really confused or distressed about, and be able to say, if we think about it this way, this opens up a different avenue of treatment that might be more effective. And then, of course, just inviting them to share their reactions, right? Not provide that diagnosis and walk away. Like, even when I do formal just assessments, provide the diagnosis as part of the debrief, always having that space for the client to share their reactions to the diagnosis, just so that they have that space to work through anything that might contribute to that feeling of being labeled and to just be able to talk through it a little bit as well.
I think that's a really great point to kind of just repeat on normalizing the terminology and asking questions about it to have a dialogue. I mean, speaking from my own experience, I wouldn't have even known really what PTSD was if my therapist didn't kind of broach that subject and educate me more on it. And it really opened up a lot of therapeutic options. So I think it's a really important thing for people to know, just kind of like shifting on that note to the therapeutic side of it.
Mhm.
Your website mentions that you use an integrated CBT approach. So can you explain what that looks like in practice? And actually, like just even kind of taking a step back, can you also explain what CBT is? We've touched on it in the past, but I think it's just good to talk about what it is, what your specific approach is, and how that applies to people with both PTSD and depression.
Yeah, absolutely. So CBT or cognitive behavior therapy, it really is kind of one model of therapy that's used across a variety of problems, not even necessarily, you know, diagnostic like mental disorders, but it can be applied across other concerns that people are presenting with. Really what it refers to is and how I think about it is a way of thinking about and conceptualizing the patterns of thoughts, emotions, physical sensations, and behaviors that are kind of arise in response to specific situations. So, like we always think thoughts, feelings, behaviors, those are interacting. They come up in response to something, they interact, they can maintain each other or create these kind of negative spirals downwards and maintain symptoms or lead to the development of symptoms and kind of cascading problems. Um, Also, thinking about how previous experiences might influence or shape those current patterns of thinking, feeling, behaving. So, cognitive behavior therapy is really is that framework of understanding and thinking about it from that perspective and then using specific skills or techniques that have been studied to intervene in that cycle and kind of reverse that loop.
Perfect segue again to my next question. Can you talk about what some of those specific techniques might be when you're working with people that have overlapping conditions?
Yeah, so there's so many. Um, the one thing I actually love as well about working from a CBT framework is that there's so many evidence-based like skills and techniques that you can actually draw on. Um, Sometimes simply focusing on the trauma first can resolve a lot of the depression symptoms, especially if those depression symptoms really are coming out of that. Um, for anything that is like coming out of trauma, I do stick closely to treatments that we know and skills that we know work with trauma. But if there is that depression or other component, what I might try to do is integrate a way of targeting those symptoms within the context of the trauma work. So, for example, prolonged exposure therapy is one of the more common ones. A big piece of it is exposure to the memory, right? Imaginal exposure, as well as exposure to situations, people, places, things that have been avoided as a result of the trauma, right? That avoidance piece of both the internal and external. You're doing it in a really systematic and tolerable way for the client. If an individual also has depression or depression features, they've probably given up certain, situations or activities and have engaged in some level of withdrawal. And so there's actually opportunity as part of the exposure work in trauma to include some of those activities that have been given up as a result of the depression and just really increasing that engagement in life again and trying to use that as opportunities to really kind of reinforce that re-engagement in life as a whole that we so often see gets like people's worlds get smaller and smaller and smaller because of trauma. And so being able to integrate to really kind of use that to continue to open up that bubble again.
You did a really great job of illustrating potential symptoms of depression and or PTSD at the start of this conversation. And a lot of our listeners will have an aha moment as they're listening to these episodes. So if anyone is listening to this and might be struggling with symptoms of depression or trauma or both, what would you say are some first steps they could take towards recovery?
After a trauma, we do know that folks who talk to someone who is a safe person are actually less likely to develop PTSD. Um, and in not doing so, again, like I mentioned, that withdrawal, kind of not feeling supported, feeling isolated are such big pieces of both trauma and depression. But, if there is someone in your life who you know is a safe person, like a psychologically safe person, um, sharing that you're struggling or that you've experienced something can be helpful. This doesn't actually mean that you need to share all of the details of the trauma that you've experienced, but sometimes letting someone know that you're struggling, who is usually in your corner, who you know will be in your corner, can just really help counter those feelings of isolation and help give you that support that you need as you start to kind of make those steps towards recovery. And then finding a trauma therapist who you think you can work with. Like you want someone who has the training, the experience to address trauma specifically, and who works in a model that resonates with you, that you feel is a good fit. Um, if you're working with a therapist right now that doesn't have trauma training, there's also no shame in having a conversation with your therapist about what you need. And even seeing a trauma therapist, someone else for the trauma therapy component specifically, and then returning to your therapist to continue the other work and that post-traumatic growth. Like your therapist should be happy to work with you to ensure that you are getting the best treatment.
That's well said. Um, if you could kind of debunk one myth or two myths, whatever you decide, about PTSD and or depression, what would you say?
I'd say one of the biggest myths and or misconceptions I see with PTSD is that people often think that the PTSD symptoms or the PTSD needs to develop right after the trauma has occurred, or it's not PTSD from the trauma. And that's true. And it's common to have an initial strong trauma reaction. In most cases, it goes away on its own. For some individuals, though, it can actually take months and even years for the actual PTSD symptoms to develop. In those cases, I often see something triggers reminders of the trauma and kind of activates those symptoms that weren't, really present or were really kind of sub-threshold before, or exposure to another kind of traumatic event reminds them of what had happened in the past and leads to the emergence of those trauma symptoms. So I sometimes hear clients say, like, I don't understand why I'm experiencing this now. It's been 5, 10, 15 years. It's like, that's totally normal. But what's really important now is that now you are experiencing those symptoms and we can address it.
You work with some complex conditions and complex situations that can obviously be really heavy for yourself and the clients. So, what gives you hope in the work that you're doing?
I think what really gives me hope and kind of continues to even invigorate what I do is the changes that I have seen when, appropriate therapy is provided. Like not just seeing the research and the numbers, because I know those numbers too, and I know that research. That's why I work in certain models. But actually having clients start believing that they're not broken or tarnished because of what has happened to them, like the doors that can open, the reduction in other symptoms that come with that, right? Those changes in beliefs and the ability to start re-engaging in life in a way that they didn't think was possible. Um, and just seeing the impacts that like that has on a person's life and even what they believe about themselves, like really gives me hope about the future, not only for them, but for other clients. And even hope in like my ability in continuing to do this work and in continuing to help individuals.
I love that. I ask this question of everyone on the podcast because we get so many great answers from this that are super helpful. So, do you have any favorite trauma resources that you like to recommend?
Yeah, so whenever I'm working with clients and we're thinking about trauma therapy, I always encourage a client to, be an active person in choosing their treatment, right? And in what's going to work for them. So for individuals who are even thinking about trauma therapy, ironically, the US Department of Veteran Affairs, and I can't believe I'm suggesting a US source right now, but they actually provide really nice descriptions of a variety of different models of trauma therapy in language that's meant to fit with a client as opposed to a clinician. And they even include video clips that describe some of them. So it's actually a really great resource for helping an individual read about the different models and approaches. And last time I checked, they even had helpful decision maker. I don't know if they've kept that up to kind of help guide you towards a treatment approach that might be helpful. And then the other resource that's really kind of helpful for both clinicians and clients um, is one that actually ties to mindfulness. So many people do hear about mindfulness and how helpful it can be. Um, but for individuals who've experienced trauma, traditional mindfulness strategies can actually create a significant amount of harm because individuals who've experienced trauma, because of that nervous system dysregulation, mindfulness strategies that are internally focused often just have them tune in to how dysregulated their nervous system is. Those that can lead to panic reactions. It's not healing. So there is actually an individual and researcher, David Trelevin, and he developed a trauma sensitive mindfulness book for clinicians and a workbook for clients. And his website actually has a podcast that has episodes that, again, can appeal to both clinicians and clients to kind of help provide a framework and understanding and strategies for, if you do use mindfulness or think it can be helpful, how to do it in a way that is healing and is helpful versus harmful with clients who have experienced trauma.
That is great. Those are actually not resources we've ever had, I don't think, which is fantastic. And we do get a lot of clinicians that listen to this podcast too. So I think that's super helpful. This conversation's been very insightful and I think, and I hope will be really helpful for our listeners. Is there anything else you'd like to share with our listeners before we close out?
One, I mean, it's been an honor to be here. I'm always happy to answer again if people do have follow-up questions about anything. And I will note, I think as I've hinted or touched on, there's lots of different approaches to trauma therapy out there. It's not a one size fits all. There is some real hope in that there's multiple models that have been shown to work. The big ones, CBT, prolonged exposure, my personal favorite, cognitive processing therapy, and EMDR, all of these approaches have been shown to work. We actually don't know what treatment is going to work best for what individual. So client preference can be really important. That's why I say clients should, be an active, participant in choosing their trauma treatment, right? If they're doing trauma therapy, find something that they think resonates, with them. Because we have these different approaches, this also means that if one approach doesn't work or resolve the symptoms, the PTSD isn't untreatable. It often just means that that model or that approach wasn't the right fit. And unfortunately, we can't quite predict that yet. It doesn't mean that it's impossible to treat. And I'm sure there are some individuals, maybe listening to this that might even feel like, you know, they've tried everything or they've tried trauma therapy and it hasn't worked. There are other options. Um, and I do, just for anyone listening, really recommend go through a round of trauma therapy. Try one that does have evidence to support it, that has a strong backing to support it, if it sounds like it might be a good fit, because Like I've said, trauma therapy, it's an investment. It's an investment of time, of money, of energy. It's challenging. So if you're doing that and investing in yourself, why not invest in one that does have that really high chance of success right from the outset? And fortunately, we've got multiple options there that clients can choose from.
Excellent way to end. I think that's the exact reason we started this podcast, is to help educate the community on the different approaches that exist, because you're right, there's so many avenues now. We're very, very lucky to be in this time where there's lots of options to choose from when it comes to trauma therapy. So I want to thank you so much for being on the show today. It's been really, really helpful. If anyone is looking for more information about Magdalen and their practice, you can see our show notes, and we will also have links to the resources mentioned as well.
Great. Thank you so much.
The Breaking Free Foundation offers therapy grants for trauma survivors in Alberta, and we also host 2 free support meetings a month. One is in person in Calgary, and one is online. For more information on trauma therapy and our organization, please visit us online at breakingfreefoundation.ca. If you enjoyed this podcast, please subscribe and share. That's all for now. Stay well.